I'm Maria Molina. I'm a second-year resident in Desert Valley Hospital, internal medicine, and I'm going to present today advanced interventions of pulmonary embolism in cancer patients. So, as you may know, any type of venous thrombosis like PE or DVT, it's very prevalent in cancer patients, even though they have 4 to 7-fold increased risk of having any type of DVT. And we have a challenge with cancer patients, especially because they have bleeding risk. And sometimes we don't offer therapies beyond what we know because of that risk of bleeding. We decide to check how is the current treatment on this population. So we did a cross-sectional study using the NIS, the National Inpatient Sample, from 2016 to 2021. And the population was adults with cancer and active PE during the admission. NIS take into account is the admissions in the national. And as we saw, we also want to check which patients receive advanced intervention, like mechanical thrombectomy and catheter direct thrombolysis. These patients, they have high risk of bleeding, so we exclude the systemic thrombolysis. But after that, we decide to do a propensity score matching to see how are the characteristic of the patient that went to the medical management and went to the mechanical thrombectomy or the advanced therapies. So what we found is, if we check here, 97,000 of the patients, they receive a total, 92 receive blood thinners, they receive the medical management. Only 5% receive catheter-directed thrombolysis, and only 0.06%, that it was 54% of the patients, they went to mechanical thrombectomy. So as we see, our cancer patients, they have more risk of bleeding, and I think that may be the reason that these therapies will not be offered to them. So as you may know, cancer is a different type of disease, so we saw hematological cancer has a 9% that they were offered this advanced therapy, and they were done that therapy. We have also other types of GI cancers besides colorectal. We have colorectal that they did the therapies in the 5%, pancreatic 3%, prostate 2%, lung cancer 2%, and breast cancer 2%. NIS, as it's a data set, and there was a cross-sectional study. So any type of mortality during the hospitalization, we also tracked that, and we found that patients with other types of GI cancers besides colorectal and lung, they were more likely to death in the admission. And the overall mortality is 11%. So we need to take account that cancer patients, they have high risk of PE. So we need to do more prevention on that case as well when we admit patients with active cancer or history of cancer. As well, major bleeding complications regarding of this treatment. All the blood thinners and all the advanced therapies, they have a high risk of bleeding. And as we saw here, 12% of the patients with other GI cancers besides colorectal, they were the highest bleeding complications in our population. When we did the propensity score, we went 1 to 4. So there were 4,000 patients that received intervention advanced, and there were 17,000 that we did with only the medical therapy. And as we found, very similar trends that we saw as well. The bleeding risk by cancer, especially, is high in other type of GI cancer besides colorectal, but colorectal is really close. So we have to be aware that our GI cancer patients, they have more risk of bleeding in the case that we are planning to use blood thinners. As well, top mortality predictors. So we have our population that is cancer and PE, and the outcome was inpatient mortality. And as we found, when we need to transfer the patient out, so we were primary center and we need to transfer to a secondary center, those patients have high risk of mortality, was 31%. So we need to be mindful when we admit a patient to a community hospital that he may have more risk of bleeding than other patients with cancer. So oncology centers are preferable to treat this type of patients. Respiratory failure, as we know, the difference in pulmonary embolism, when you start to have elevated troponins, RV strain, you start to have more complications, and then you can offer an advanced therapy. Acidosis, as we know, is also one of the risk factors for death, sepsis, renal failure, and metastatic disease. So the key home messages that I want to bring is our patients with cancer, they're more prone to have a PE. Treatment has to be tailored due to the risk of bleeding. We have to think in patients that had GI cancers, but we need to offer them something else besides just blood thinners. But we need to tailor, especially we know all the consequences that has pulmonary embolism as pulmonary hypertension and another that can decrease the quality of life in our patients. Thank you.